It's a pleasure to be here with you today and to have an opportunity to review some of the science of our perioperative NPO guidelines and what we're doing because of those guidelines to change the way we give instructions for patients. Let's take a step back and think about some of the things we've done over the years to improve surgery and surgical outcomes. Think about some of the topics you've heard today. Think about the things you see in the operating room. We have intraoperative CT, radiation, stereotactic guidance. We have minimally invasive surgery, smaller incisions, robotic-assisted surgery. Think of the days before we had ultrasound-guided nerve blocks, peripheral nerve catheters, and these are all new and very exciting things. But there's one thing that over the years has not changed, despite what studies have shown and what guidelines say we could do. We still can't get away from telling patients to be NPO after midnight on the day of surgery. That little gentleman in the picture, he just wants a little toast and some coffee. He's not asking for much, but obviously he was told something different. What I hope to show you today is that the culture of NPO after midnight is not based on science. In fact, maybe it's just a simple thing is that we're afraid that our cases might be canceled or delayed. First thing to get straight is the history of NPO after midnight. And the practice of telling this to patients is nowhere written in the anesthetic guidelines. In fact, 17 years ago is when the first time it was declared that it was safe for patients to have something to drink 2 hours before having surgery and 6 hours to have a meal. Moreover, more than just being safe, over the years what we're starting to realize now is that in fact patients may be better off if they have something before they come in for surgery. To help me better explain, let's take a second just to review some of the normal physiology a little bit. This is a picture of normal metabolism in a healthy patient with, who is not in a stressful state, i.e. this patient is not having surgery. You can see that in the center over here, that the body needs energy and fuel for cellular function, muscle function, and tissue repair. And the main source of that energy is carbohydrates. If you eat more calories than you need, then obviously it gets stored as glycogen or fat stores. But after a period of fasting, things start to change. The metabolism switches away from the stuff you eat to more of that fatty acid and glycogen breakdown that you stored up previously. For prolonged fasts, you start to get lean muscle loss and protein and muscle breakdown. Surgery gets everything, exaggerates everything much more so. As soon as you make an incision, the body enters this hypermetabolic state where you start getting hyperglycemia, you have this huge demand for energy, you start getting even more protein breakdown, fat breakdown, and it's all a response. It's actually a normal response to surgery, but it's when you get to the point of it being an exaggerated response is where you get into trouble. And it's a pretty profound response. For certain surgeries, you look 2-3 weeks out, people are still hyperglycemic and they still have insulin resistance. And this is a problem for them because many studies have shown that hyperglycemia increases postoperative complications, heart attacks, infections, and even increased in mortality. How about protein metabolism? Patients can't afford to lose muscle mass after they have surgeries. In fact, it could take up to 6 weeks of intense rehab to regain just 2 weeks of muscle loss after somebody was immobilized for an injury. And for certain surgeries, if you look 2 months out after their surgery, almost half the patients are still not back to their functional preoperative walking status. So patients can't afford to lose muscle mass. And as for infections, I think everybody knows that surgery puts you in an immunocompromised state. But what most people don't realize is that the degree of postoperative immunocompromise is related to the duration of preoperative fasting. So I think you're starting to get a sense of what I'm trying to say here, the goals that we should have for our patients. First thing is we want to minimize that surgical stress response that we talked about. And the second thing is we want to provide the nutrients that patients need to handle this hypermetabolic state that they're in. And I think most people have a good grasp of what we do every day to minimize surgical stress. Smaller incisions, preoperative antibiotics, regional nerve blocks, multimodal pain medicines. But what about the importance of preoperative fasting and the duration of preoperative fasting? This is one study. It's not that big, but it did show a pretty interesting relationship between taking preoperative carbohydrate drinks and how it affects physiology. The people who had a preoperative drink had significantly increased intraoperative glycogen stores, so they had more fuel for their surgery. But even more interestingly, 50 to 400%, they had a 50 to 400% decrease in the inflammatory mediators that lead to muscle wasting. These are two reviews. The first one is a review of 17 randomized controlled trials in over 1,400 patients, where they looked into the role of preoperative carbohydrate loading before surgery. And what they found is that patients who had a drink before having their surgery, a carbohydrate drink before having surgery, had an increased incidence of patient comfort, including anxiety and post-op nausea vomiting. The second study is also reviewed. This one's in colorectal patients. And what they found is the patients who had a drink had a shorter length of stay, quicker return of bowel function, less muscle mass loss, and again, a reduction in post-op nausea and vomiting. But that study was in colorectal surgery, and a lot of what I'm talking about has its origins in enhanced recovery after surgery. I think a lot of people in this room are realizing we have a few enhanced recovery after surgery protocols coming around, being worked on in this hospital. And basically what ERAS is it's more than just preventing preoperative fasting. It is other 15 to 20 other things that the protocols call for to decrease the surgical stress response and to improve outcomes. But ERAS is not just for colorectal surgeries. This is a cohort, a study that followed a cohort of 428 patients who had hip fractures. And what they tried to do is try to find what the risk factors are that would lead to worsened outcomes. And what they found that fasting greater than 12 hours was one of the major risk factors that predicted in-hospital complications, post-operative confusion, and even death within four months. So I think just starting to understand why a lot of people in this room are working to try to change the way we give patients instructions. And I think we may be getting to about a quarter to a third of the patients that we take care of that in one way or another, either the surgeons or the nursing staff are giving them instructions that you could have something to drink as long as it's within the guidelines of having a drink 2 hours before surgery or having a light breakfast if you have an afternoon surgery. So I appreciate everybody's help with that, and we've come a long way. It's not a easy thing to do, but we definitely have come a long way. So I just want to share with you some of the things we've learned. One of the most important things we've learned that it really takes everybody to get on board. You need the surgeons, the anesthesiologists, you need the office staff, the facility nursing staff, patients, family members, operating room schedulers. Everybody has to have a good idea of what these guidelines are and what is the best way to give instructions. And everybody should give the same instructions. And to that effect, what we did is we came up with a card that could be used for clinical staff. This one's not for patients, where it describes those things. It describes what the guidelines are. It gives you ideas of how to instruct patients. It gives a definition of what a clear liquid really is and what a light breakfast could consist of. And it gives some other important pieces of information. For example, if there's a case cancellation or a change of surgery, change in surgical time, it kind of reminds people you gotta call some other patients because their NPO times might have changed. So there's a lot of things to think about, and everybody has to be thinking about the same thing. Along the same lines, we have a sheet that was designed for patients. It actually has much of the same information, but obviously a lot more simpler. One example of making things simpler is most patients, especially the ones who have morning surgery, are just given 2 times. They're told when to arrive at the facility and when to stop drinking their clears. Because if there's surgeries in the morning, they're not going to be having a light breakfast in the morning. And that makes it a lot easier than how we used to do in the past. In the past, patients would say, your surgery's at 2 o'clock, you'll probably be done with your surgery at 4:30 in the morning. Come into the hospital maybe an hour before your surgical time starts. And then you have to do math of what's 2 hours before surgery and then 6 hours. It just gets too complicated. So we could use this, and they could actually write down their times during their preoperative phone call or during the visit to the surgeon's office. And all these things have really helped to make things easier for patients. What are the next steps? Well, obviously the next step, I just want to get as many people on board with this. I know we have about a quarter to a third of patients that may be getting these instructions. And sometimes it's just instructions from the nursing staff, and some of the offices don't have some of these handouts that we have. So I think the main goal in the future is to get more people in the entire community to give these instructions. There is interest in our pediatric population, some of the pediatric surgeons who think this is a great idea for little kids as they're coming for surgery, so they're not NPO after midnight for a very long time, especially little kids who are still breastfeeding in the middle of the night. So we're working with that. There is interest in our OB population for patients coming in for a C-section. But all these are special populations, and they'll require additional input from you guys, from the nursing staff, from the surgeons' offices. And I think in the end, right now we've started with many early adopters, and many of the early adopters are here in this room. But eventually, once we get a critical mass, my sincere hope is that everybody who's having surgery with us will be told that, hey, you'll feel better if you just have something to drink before you come into the hospital, and maybe it'll actually improve some outcomes for you. So I hope that was helpful. If there's any questions, I guess we'll answer them soon.